Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, I'm going to be covering elective induction of labor. I'm also going to be covering the medications and the adverse effects and nursing interventions regarding those medications for inducing labor. So before we even get started, guys, you know you're going to like this video. Go ahead, press that like button, subscribe to this channel, and press that red notification button so that every time a new video is released, you'll be notified. So let's get started. Let me scroll down for you. Induction of labor. So induction of labor, this is the chemical or the mechanical initiation of uterine contractions. Guys, those uterine contractions is what actually what actually pushes that fetus out the birth canal, right? Initiation of uterine contractions before their spontaneous onset for the purpose of bringing about birth. What is that telling us? That's telling us that induction of labor is having mom go into labor before she was naturally ready. So it's not like her water broke on her own and now she's going into labor. No, we're actually inducing this labor, okay? Before labor induction, prior to labor induction, the gestational age should be determined and any potential risks to the maternal fetal units evaluated. Why? We need to make sure that that fetus has enough surfactant, that fetus is old enough that when mom pushes out that baby, it survives outside of the womb. So that's very important. That's one of the most important reasons why we have to check the gestational age. Elective induction of labor. All right, so an elective induction is one in which labor is initiated, look at this guys, without medical indication. So it's not medically necessary, but maybe mom wants this particular doctor and the day that she's naturally supposed to give birth, he's golfing, right? And so they schedule induction of that labor. So induction of labor doesn't always have to be medically necessary. Methods to ripen the cervix, that means to make that cervix ready, okay? Methods to ripen the cervix, such as application of prostaglandins or intracervical insertion of a balloon catheter, they enhance the likelihood of successful induction. To prevent iatrogenic prematurity, look at this, elective induction of labor should not be initiated until the woman reaches 39 completed weeks of gestation, because we know, guys, by 39 completed weeks, that fetus will have enough surfactant that they should be able to survive outside of that womb. That is very important. This right here, this box 17.7, this is all over NCLEX, HESI, ATI. This is important for you guys to know. It says indications and contraindications for labor induction. So what are some situations where we would induce labor and what are some situations we would not? So let's take a look. Maternal indications. So for the mom, why would we induce labor? Hypertensive complications of pregnancy, gestational hypertension, preeclampsia, eclampsia. Did you know that the only cure for preeclampsia, that gestational hypertension, is what? To give birth. Okay, so a maternal indication of inducing labor is if mom has one of these. Here's another indication, fetal death. If that fetus died inside the womb and it stays inside mom's womb, she's going to get a septic infection, right? So that would be another indication that we would induce labor. And chorioamnionitis. That infection, absolutely infection of the amniotic fluid, right? So that would be another reason that we would induce labor. Fetal indications, so towards the fetus, why would we induce labor? Any condition in which a variety of tests demonstrate significant, that means a lot, significant fetal jeopardy in any of the following situation: diabetes, post-term pregnancy. And I'm not going to go over all of these, guys. You can read it on your own. I'm just touching up on the ones that most likely you need to know for your nursing exams, but I don't write these tests, guys, so make sure you know all of them. Now, where it says post-term pregnancy, look at this, especially when oligohydramnios is present. What is oligohydramnios? When mom doesn't have enough fluid in the amniotic sac, okay? Chorioamnionitis, again, that infection and premature rupture of the membranes with established fetal maturity. That's important to us, guys. So not only premature rupture of the membranes, we need to make sure that we have established what? Fetal maturity. So we know that the chances are high that that fetus will survive outside of the womb. So it's okay, let us go ahead and induce labor. Now look at all of these contraindications. When would we absolutely not induce labor? Acute severe distress. If that fetus is in acute distress, do you think they would be able to handle the stress of those contractions? No. Shoulder presentation, transverse lie. Okay, that fetus is in a transverse lie. How's it going to get through the birth canal? Floating fetal presenting part. Absolutely not. Uncontrolled hemorrhage. Woman's already bleeding, possibly bleeding to death. Does that make sense? Absolutely not. Excuse me. Guys, I'm sorry. Placenta previa and previous uterine incision, that prohibits a trial of labor. So all of these guys are contraindications that we absolutely would not induce labor. Chemical, mechanical, physical, and alternative methods are used to ripen. Again, that when they say ripen the cervix, that means to make that cervix ready for those contractions, to ripen this and dilation, I should say, to ripen the cervix and induce labor. Look at this, guys. You need to know this. IV oxytocin, which is your Pitocin, and amniotomy, these two are the most common methods that are used in the United States. Pitocin and amniotomy. Those are the two that they use the most to induce labor. Cervical rightness is the most important predictor of successful induction. We need to make sure that cervix is ready, because remember, the cervix has to what? Dilate, which means get wider, and it has to efface. When you see that word effacement, I want you to think of that cervix basically folding over itself. And I think this book has a nice picture. I'll show it to you. So it's very important that you know that cervix dilates, gets wider, and effaces, because when it effaces and it basically folds over itself, it gets thinner. And that's what we want. We don't want it thick. We want it nice and thin, okay? So excuse me, I think I misspoke before when I said contractions. I want you to understand with the cervix, it dilates, which means it gets wider, right? And it effaces, which means it gets thinner because it's folding on top of each other. Folding over itself, I should say. So look at this. The rating system, such as the Bishop score, you guys have to know that, can be used to evaluate inducibility. The higher that score is, the more ready that the cervix is to be induced, okay? For example, a score of 8 or more on a 13-point scale indicates that the cervix is soft, anterior, 50% or more effaced, and 2 centimeters dilated or more, and that the presenting part is engaged. Look at this. When the Bishop score totals 8 or more, this is the second time we're seeing 8 or more, the likelihood of vaginal birth is similar whether labor is spontaneous or induced. The Bishop score should be documented before the use of methods to ripen the cervix or induce labor. Why? Again, guys, that Bishop score is what we use to evaluate how ready mom will be for induction. Okay, that's what we use. So the higher the score, the more likely it is that that cervix is ready to be induced. Now, if you take a look at this, this is a Bishop score, and again, guys, it shows the cervical rightness, cervical readiness, cervical inducibility. You hear those words, they're all talking about the same thing. The higher the score, the more rightness, the more inducibility that the cervix has. So let's talk about cervical ripening methods, chemical agents. So preparations of prostaglandin E1, E2 have been shown to be effective when used before induction to ripen, to soften, to thin the cervix. You guys have to know those two medications. We're going to talk about them. So we have misoprostol cytotec and prostaglandin E. Dinoprostol, that's your Cervidil. In some cases, some women spontaneously begin laboring after administration of prostaglandin, thereby eliminating the need to administer oxytocin to induce labor. Let's stop right there because I gotta make sure you guys understand what that means. Let's go back. So sometimes spontaneously, after the woman gets prostaglandin, remember prostaglandin, that's what softens the cervix. That's what ripens the cervix. But after she gets that prostaglandin, she automatically goes into labor, right? Those contractions come on. So there's no need to give Pitocin because remember what Pitocin does, Pitocin / oxytocin, what? It does what? Brings on contractions. But we see this in some cases, as soon as mom gets that prostaglandin to ripen the cervix, she starts having contractions on her own and we don't have to give the Pitocin. Additional advantages of prostaglandin used for cervical ripening include, you need to know this, decrease oxytocin induction time, and I just explained to you why, and a decrease in the amount of oxytocin required for successful induction. So it's like we're killing two birds with one stone. That prostaglandin, not only is it ripening that cervix, it's softening it, it's making it ready to be induced, it allows us to have to give less oxytocin, or maybe we don't even have to give any oxytocin. Okay, although the drug's manufacturer has acknowledged for several years that prostaglandin is effective for cervical ripening and labor induction, look at this, guys, it has not yet been approved by the FDA for these uses. What does that tell us? That tells us that when we use it, even though we do it all the time, we do it all the time to ripen the cervix. When we use that prostaglandin to ripen the cervix, it has not been approved by the FDA for that purpose. And so that's an off-label use. Remember, in pharmacology, you learned about off-label uses when you're using one medication for indication of something that has not been approved by the FDA. That's one of them. You need to know that. All right. ACOG, however, considers the use of prostaglandin for pre-induction cervical ripening to be a safe and effective off-label. You guys need to know that. Off-label use of medication. Now, the PGE2 in the form of a vaginal insert, that's your dinoprostone, although more expensive than prostaglandin, has major advantage of easy removal, should adverse reactions including uterine tachycystole occur. You need to know this. Let's take a look at this. Prostaglandin, misoprostol. All right. So action, again, we know what the action is. It ripens the cervix, makes it softer, and causes it to begin to dilate and efface. It stimulates uterine contractions. It should not be used if the woman has a history of previous C-section or other major uterine surgery. That is very important for you to know. That is a contraindication. If she's had a C-section before, or she has a history of some other type of uterine surgery, we are not going to use that on this patient. Important nursing considerations. Again, guys, I don't write your test. Make sure you know all of this. I'm just going to go over the most important ones, okay? You want to assess maternal vital signs and health status, fetal heart rate and pattern, and status of pregnancy, including the indications for ripening that cervix or inducing that labor, okay? Avoid giving aluminum hydroxide and magnesium containing antacids along with misoprostol. You better know this. Don't say I didn't warn you. Have the woman void before insertion, because remember, a full bladder may cause shifting, right? Assist the woman to maintain a supine position with a lateral tilt or side-lying position for 30 to 40 minutes after the insertion. You want to prepare to one, swab the vagina to remove unabsorbed medication using a saline soap gauze wrapped around fingers, or two, administer terbutaline. And you see this dosage, you have to know that. It's not enough to know you're going to give terbutaline. You have to know how much. 0.25 milligrams subcutaneously if the patient has an adverse reaction. So you got to have that 0.25 milligrams of terbutaline available right there at the bedside, prepared in case the patient has an adverse reaction. How much are you going to give? 0.25 milligrams. You're going to initiate oxytocin to induce labor no sooner than 4 hours after the last dose of misoprostol was administered following agency protocol. Why? Because we know that that patient can go into labor and start having contractions on her own. Okay, that's why it says no sooner than the 4 hours. Make sure you read the rest of that on your own. And this one's the dinoprostone, Cervidil. Action, again, to ripen the cervix, makes it softer, causes it to dilate and efface, stimulates uterine contractions. That's why we normally have to give less of what? The oxytocin and the Pitocin. Indications, why would we give this? It's not recommended for use if the woman, again, has a history of C-section or other birth or uterine surgeries. Again, look at this, guys. Avoid in use in women with asthma. I wish I had a pen here. I never have a pen when I'm teaching you guys. Matter of fact, asthma, this is seen often on nursing tests. That's an example they use a lot, the asthma, okay? Avoid in use in women with asthma. Glaucoma, what's glaucoma? That's that increased pressure in the eye, right? Hypotension or hypertension. Bring the gel to room temperature just before administering. So you cannot get this medication out the fridge and just give it, okay? You have to bring it to what? Room temperature just before administering. Do not force the warming process, which means you can't put it in the microwave. Do not force the warming process by using warm water bath or other source of external heat such as microwave, because heat can cause it to be inactivated. Keep the insert frozen until just before insertion. No warming is needed. You just want it room temperature. Have the woman void before insertion. We don't want a full bladder. You're going to assist the woman to maintain a supine position, again, with a lateral tilt or side lying, and stay in that position for at least 30 minutes after insertion of the gel, or for 2 hours after placement of the insert. Allow her to ambulate after the recommended period of bed rest and observation. This is important. You need to know this. Prepare to pull the string to remove the insert and to administer terbutaline 0.25 milligrams. How? Subcutaneously, if significant adverse reactions occur. Delay the initiation of oxytocin. Remember, oxytocin, that's what actually causes these contractions. You want to delay the initiation of oxytocin of labor for 6 to 12 hours after the last installation of the gel, or for 30 to 60 minutes after removal of the insert, or follow agency protocol if ripening has occurred, but labor has not begun. Okay, guys, so the last thing I'm going to talk to you about is the amniotomy. That's the artificial rupture of the membrane. So basically, mom's water isn't breaking on its own. We're doing that for her, okay? So here it says amniotomy, artificial rupture of membranes, can be used to induce labor when the condition of the cervix is favorable, as in is ripe. So let's talk about the procedure right up here. You're going to explain the procedure to mom, husband, whoever's there. You're going to position the woman on padded bedpan, fracture pan, or rolled up towels to do what? Elevate the hips. That's the whole point. You need those hips elevated. You're going to assist the healthcare provider in performing the procedure. You need to assess the color, the consistency, and odor of fluid, okay? We want to make sure there's no infectious process happening. Assess the woman's temperature every 2 hours or per hospital protocol. Evaluate the woman's risk for signs and symptoms of infection. Because remember, guys, anything we do that is invasive, there's a chance of us introducing bacteria and causing infection. She's at high risk for infection when it comes to amniotomy. So we have to be watching her closely, taking her temperature, looking at those WBCs. When it comes to documentation, you're going to record the fetal heart rate and pattern before and after the procedure. Before, we need a baseline, don't we? The time of rupture, the color, odor, consistency of the fluid, and the maternal status, how well the procedure was tolerated. Guys, there is so much to cover when it comes to OB, so I promise there are going to be lots more videos coming your way. If there's anything specific that you'd like me to teach on, please just let me know in the comment section. I promise I have an ever-growing list that I will add your comment to. Let me know what you thought of this video, what you'd like to see more of. And you guys, oh, don't forget, guys, I have audio lessons available for you on my website, nexusnursinginstitute.com. Thank you for watching this video, and you'll be seeing me on my next video.